Hello there, Sarah. My name's Anthony Quadra. I'm one of the doctors. Is it okay if I examine your eyes?
Of course.
Okay, thank you very much. I'm going to be using a bright light. Don't worry, it won't be doing you any harm, and I'll be coming in quite close. I just want you to look at the distance target there. And if you could just stay looking there, even if I get in the way, just imagine you can see through me. Can we please have the lights dimmed? Okay, Sarah, could I ask you to just look into my light for me, please? Thank you very much. Can I ask you to look up to the ceiling, please? Thank you. And down to the ground, please. That's good. And can you look across to the left, please? Thank you. Great. And just all the way over to your right. Thank you. Okay, thank you. We'll just examine the other eye now. So again, if I could have you looking into the distance and just ignore me. And now look at the light for me, please. Thank you. That's great. And can you look up for me, please? And look down for me, please. Now look over to your right for me, please. Thank you. Brilliant. If you could look over to your right for me, please, all the way over. Thank you. That's great. And all the way over to your left, please. Thank you. Thank you very much. Fundoscopy is a difficult technique to master and only comes with practice, but there are a few important steps which should help ensure success. So after introducing myself, I explained what was going to happen. I think it's important to say there's going to be a bright light and it's not going to be doing them any damage. It's important to say you'll be getting up close so that they don't feel uncomfortable and they feel prepared. And when I do that, I actually pop my hand on the patient's forehead, which gives me a guide as to how close I am. It also gives me a chance to lift up the upper lid, especially when asking the patient to look down. I also ask them to fixate on a distance target and to not look around just because my head gets in the way, so to look through me. And I think that sets you up nicely. The next step, after they're looking in the distance target, Sarah, would you mind looking at the distance target? Thanks. Is just to look at the red reflex for that eye. And it should be nice and clear and red, and if there's any opacities, then one knows that there might be a cataract or a vitreous hemorrhage or something like that. Then come in slowly and aim for the opposite ear. So it's important as you're coming closer with your forefinger to be racking through the lenses up and down to make sure you're keeping a good focus. First on the front of the eye, then on the iris, then back to the lens, then through the vitreous, which you won't be able to focus on if there's no hemorrhage or such, and then down onto the optic disc. If you've aimed towards the opposite ear, then you should hit the disc straight away. Focus on the disc, look around the disc, check its contour, its circumference, is it clearly visible, its colour and its cup. Then look around at across all of the vessels and see if the vessels look healthy or if there's any other retinal pathology. Then I ask them to look at the light so you can assess the macula. I do that after I've assessed everything else because the macula might be a bit dazing. Then if you have time, you can assess the peripheral retina by asking the patient to look up, down, left and right, as I demonstrated earlier. Fundoscopy of this lady's right eye revealed multiple flame-shaped hemorrhages in the infratemporal quadrant of the retina. There were also a few scattered cotton wool spots. There were no new vessels at the optic disc or elsewhere in the retina, and no vitreous quadrant of the retina. There were also a few scattered cotton wool spots. There were no new vessels at the optic disc or elsewhere in the retina, and no vitreous hemorrhage. There was whiteness of the vessels distal to all the hemorrhages in the infratemporal quadrants. These findings are consistent with an infratemporal branch retinal vein occlusion. The key features of this case are recognising that this was a vein occlusion, the flame-shaped larger hemorrhages as opposed to the smaller hemorrhages one sees in diabetic retinopathy. Recognising the sectoral distribution, so this was a branch vein occlusion because it was only in one quadrant, as opposed to a central retinal vein occlusion which would have hemorrhages in all four quadrants. Picking up the fact that there was an occluded vessel distally is useful. Cotton wool spots again represent ischemia and infarction of the nerve fibre layer. Mentioning important negatives, that there were no new vessels on the disc or new vessels elsewhere or vitreous hemorrhage, shows that you understand the potential sequelae of a branch vein occlusion if it is ischemic.